Hello, I'm Dr. Sagar Lonial, and we're here at the IMW meeting in Boston. I'm joined by my colleagues Enrique Ocio from Spain and Rafael Fonseca from the Mayo Clinic. And we're going to talk about a couple of really exciting hot topics from today. So why don't we get started on what I think is really potentially cool, and that's MCL1, targeting MCL1. Enrique, you want to tell us a little bit about the information?
I think that's, for me, that's one of the main highlights in the meeting, because we have heard a lot about MCL1 in the preclinical setting. We have heard about how 1Q can influence MCL1, some mechanism of resistance to BCL2 also involving MCL1. So I think MCL1 has been like one important point here, and also that has ended up with a clinical trial. So we have the first results of an MCL1 inhibitor, AMG, and I think the results were, well, are very preliminary, but we have some responses and good tolerability profile. So I think it's interesting.
Yeah, I mean, I think if you think about what myelomas will preferentially be sensitive to, while we'll talk about venetoclax and BCL2 in just a moment, MCL1 is by far the more dominant player, I think, right?
I absolutely agree. So I think this is one of the most promising targets we have now. Well, we will see how it goes.
Okay, all right. Well, let's switch to BCL2 then and venetoclax. There was some interesting data in plasma cell disorders presented today as well.
Well, I think there were two things that were remarkable, and one is the update that Shaji gave us on the Bellini trial, which I think he had made some similar comments at the EHA meeting. But the point is, once you start drilling into the details, what do we expect that you're going to find? That the reality is that for patients with 1114, you see a remarkable effect for venetoclax. So I'm really eager so we can get forward and moving with the rest of the clinical trials. There's no doubt in my mind this will be a very important drug for patients with 1114 or 1114-like. I think we're still defining that. You know what was great too is there was a session with the group from Dana-Farber presenting on venetoclax for Waldenstrom's. And while we have very good treatment options for Waldenstrom's, this appears to be one new drug that will enter into the trial arena, and ultimately the armamentarium against Waldenstrom's with a high rate of response, similar tolerability as you see in other plasma cell tumors. So stay tuned to venetoclax. It's a little pony, the 15%. It's not quite MCL1, but it's quite exciting.
Yeah, you know, it's really interesting when you think about Waldenstrom's. I remember talking to Emory 15 years ago, and response doesn't mean anything because it's such a long-lived disease. And now we have ibrutinib and potentially venetoclax in a combination, and you may actually see CRs that could be quite durable, right?
Well, that's what they're seeing in CLL, right? Just remarkable results. And it's very interesting because even though it's a neighbor to myeloma, genetically they're completely different, and then they don't share mutations. In fact, some drugs don't work and work on the other, but then there's some commonality like we're seeing now with venetoclax.
Yeah. Tell me about your experience with venetoclax in myeloma.
No, really, I don't have much experience with that. That's in clinical trials and some patients, but I think that the experience, the results are really good with venetoclax. And I think, but probably for me, the most important point for venetoclax is that it's a targeted agent, and we can select those patients that would respond. I think this is for the first time we have a good biomarker, 1114. And this is good. I think this is probably the way to go in some patients, with some drugs we have in myeloma.
Yeah, I agree. So cellular therapy has been a buzz for at least a year and a half now in myeloma. We saw a lot of updates and discussions on NK-targeted cells, CAR T cells with lots of different vectors. What struck you all?
What strikes me, the development we have, the fact that there's an educational session that we're talking about strategies for mitigating toxicity with CAR T cells. Of course, we don't have a commercial product for myeloma. Hopefully that will happen in the near future, but I think we have a much higher level of understanding, plus a clear path. We heard about allogeneic strategies with allo CAR T cells. We're hearing, as you mentioned, with NK cells. Of course, on the side, there's all this development with bispecific and like technology. So I think it's only logical to assume that this will be part of our treatment toolbox as well.
No, also I think that you have also the humanized CAR T. So you have many different ways we are trying to optimize to prolong the response, because we know that they respond, but sometimes the response is not so durable. So how we can improve that, improve the tolerability. Now I think we have got used to that, but we have in every meeting we have CHA, we have a lot of talks, maybe 5, 6 talks of CAR Ts, different CAR Ts, and at the end you don't know what is the difference between one or the other, but you have a lot of them, and all of them with similar results.
Sagar, one of the most interesting things you presented on iberdomide and some of the updated results. Why don't you share that with the audience as well too?
Yeah, I think it's a really neat compound, and I was a little skeptical. Could you really overcome POM and LEN resistance with CC220, which we now know as iberdomide. And I will tell you, I've been really struck by two things. One is the response and durability of those responses. We've got somebody that's probably almost on for 2.5 years now. And the second is the tolerability of this approach. It's actually an easier drug to give than either POM or LEN in terms of adverse events. And yeah, there's some cytopenias depending upon the dose you're at, but in general, the GI stuff that we see with LEN does not appear to be an issue. No neuropathy, no other major signals, and I think it partners nicely with other drugs in phase 1 with either DARA or CARB or bortezomib, which I think tells me it's going to be an important part of our treatment.
And we wouldn't do a good job if we don't mention the JSK product as well, too, right? So, I mean, talk about a myeloma meeting where we're talking about 4 or 5 new different things right here.
Yeah, I mean, I think as exciting as CAR T cells are, I think the door is still pretty open for BCMA-targeted approaches, and whether it's the AMG 701 that we saw some preclinical data on, we know that AMG 420 had activity, but it also had some challenges, or antibody-drug conjugate with the GSK compound. I think we've got a lot of different ways to get at BCMA.
Sure. And also we have some other bispecific that are also coming. We don't have the results yet, but I think this field is growing a lot. We have a lot of things that coming, and we have to be, as you said, tuned just to know what.
That's an important point. We have CAR T cells that are targeting, the SLAM-F7CS1. We actually are working with a bispecific targets another molecule FcRH5.
Yeah.
So I think that the idea is just to find those that are going to be very, very specific, and I think there's going to be, even with that, more trials.
Yeah, sure.
Yeah, really exciting day at a pretty exciting meeting, I think, overall.
Absolutely.
Absolutely.
All right. Well, thank you all very much for your insights and approaches for today, and we'll get back to the meeting.